Welcome to all our participants. Today's webinar is entitled New Year, Time to Debunk Myths on Vaccine. The objectives of today's webinar are: first, describe the scientific basis for vaccine. Second, list common misconceptions about vaccines. Third, analyze the impact of the Dengvaxia issue on vaccine use in the Philippines. And fourth, discuss ways to address these myths, misconceptions, and misgivings about vaccine. I'm very proud to introduce our speaker today, Professor Lulu Bravo. She is a Professor Emeritus at the College of Medicine, University of the Philippines, Manila, and a former Vice Chancellor for Research, as well as Executive Director of the National Institutes of Health, UP Manila. And she is the foremost expert on the science of vaccines and immunization. Was the founding president of the Philippine Foundation for Vaccination, and at present is the president of the Immunization Partners in Asia Pacific, or IPAP. Her work has earned her various honors and awards in the academic and research fields, including the Dr. Giuseppe Rizal Memorial Award for Academia and the 2012 Asian Outstanding Pediatrician Award given by the Asia Pacific Pediatric Association. Dr. Lulu Bravo completed her medical degree, pediatric residency, and subspecialty training in infectious disease at the Philippine General Hospital, College of Medicine, and at the University of the Philippines, Manila. She supplemented her fellowship in pediatric infectious disease at the University of Texas Southwestern Health Science Center in Dallas, USA in 1986. May we now call on Dr. Lulu Bravo.
Yes, good afternoon, and thank you very much, Tricia, for having me here and the UP webinar. This is my third appearance, I think. And I love this topic because it says, New Year, time to debunk vaccine myths. First of all, my disclosure, I have had honoraria for researches from these various companies, and definitely, I would like to think that I am a vaccine advocate. So for our afternoon session, I would like to really review with you the scientific basis of vaccination, list the common misconceptions about vaccines, analyze the impact, and this has really been a hot issue, the impact of Dengvaxia on vaccine use in the Philippines, and maybe discuss some ways and means to address these issues and improve the vaccine confidence that has plummeted through the years, through the months that we have here. Now, to review, how does this vaccine work? Actually, vaccines are biological substances that, when administered, can produce active immunity, a protection that is provided by the person's own system. That is for active ones. This active immunity are also developing after an infection with disease-causing organism, but it does come after vaccination too. Usually it is long-term. The other kind of immunization or vaccination is when you protect the body through the transfer of maternal antibodies, for example, or passively antibodies going into the other human body, like when you have maternal antibody transfer through the placenta to a baby, or when you give IgG to a patient who might be suffering from a disease. This usually is temporary and wanes with time. Something like this is what we usually think about vaccine. It's like having a natural infection. The vaccination produces the immunity, and this triggers a response that would normally follow recovery, similarly from a natural occurring infection. But with vaccination, you do not, or the vaccinee does not endure the illness, and that there is a low risk of adverse reaction. If there is such a reaction, it is usually very minimal and not really a high risk at all. So, we have had many discussions on what the ideal vaccine should be. Forward, we want a vaccine that will be safe even in immunocompromised people. See, that's the primary thing about vaccine. It should be safe. And second, it should be highly effective and optimally induce sterilizing immunity. Now, secondary requirements, of course, are needed because not all vaccines are similar. But what we want is a vaccine that is not so expensive. Ideally, way back 1990s, we say ideally it should be less than 50 cents per dose. But you know, price is always relative. Now we talk about cost effectiveness of the vaccine instead. And then it is preferably easily administered. If it can be given oral, why not? That's the best way to do it because injections are always accompanied by more side effects or more reactions. And then because we are in a tropical country, we need a vaccine that has high thermal stability, that cannot easily be destroyed or damaged by heat, right? Because cold chain is so expensive also. And then it's a vaccine that can protect many kinds of serotypes of an organism. It has to be multivalent because some organisms are really composed of different proteins or different serotypes. And one vaccine may not be enough to protect them from just one organism, just like in pneumococcal vaccination. And of course, it has to be a long-lived immunity. Now, what do we mean by safe? Since this is the first requirement for an ideal vaccine, safe, we always say, you know, you don't get any harm. And, you know, when you have a sickness, a disease, you always get to be at risk of complication. Now, a vaccine is supposed to be seen as no harm from the vaccine. But we all know now that no vaccine is 100% safe, just like any drug. It's not 100% safe. No vaccine can ever be 100% safe nor 100% effective. And that's the reason why we have to remind our parents that if you do not do anything to take a risk, there's always that minimal risk, even in vaccination. If you do not do anything, you might really be in real danger from a disease that your child may be exposed. Vaccines are safe because the danger they prevent, the diseases, far outweighs the danger or the side effects that they represent. And because of this, vaccine safety is again at the top issue about vaccines. And the misconceptions that we have been having all these years is whether or not this vaccine is safe. Take, for instance, these examples that I have listed down. Thiomersal and autism. Wow, people started to think that with the use of thiomersal, which is a preservative that's used for vaccine, that you can cause autism. And because some people really have been seen with autism, they thought, yes, it could have been because of thiomersal. And many manufacturers, and actually at about this time, thiomersal has already been removed from many of these vaccines. Very, very few. And in fact, it is the drugs that sometimes have thiomersal, but you continuously take them. For vaccines, it's almost gone. The thiomersal have been gone. But let me say that never has it been shown that thiomersal has a bad effect of autism produced by this. So the same with MMR, vaccine and autism. Way back in 1998, it was Andrew Wakefield who has now been, how do you call it, removed. This paper that he published has been removed and has been debunked, and he himself has already been withdrawn. His license has already been withdrawn, you know, this Andrew Wakefield, because that paper that showed him associating MMR vaccine and autism did not actually support that idea. And there was no evidence, and I will show you in a little while why this is so. And the same with many of these lies about sterilization and the use of tetanus vaccine. This was also used during the time of Dr. Flavieri, remember? Because people thought that tetanus vaccine was being used as an abortionist substance, or that it can really cause mothers to not just lose their babies, but to become sterile in the future. The same with oral polio. However, all these are not evidence-based. Now, it's not just about vaccine safety. If you talk about misconception, there are other misconceptions about vaccine. It doesn't have to do with safety. And as I said, there are others. And one of those is affordability. Because vaccine is a public health issue. You give it to healthy people. You give it to a mass vaccination sometimes. Cost is very important. And people always ask, are we able to afford this? Is it not too much to spend for such vaccines? But I can tell you, if a vaccine can really prevent severe disease and deaths, even one death, because if that is your child or that is a loved one, death is always a bad thing if you can prevent that death. It is always a poor excuse that, it is very expensive. Mothers would always tell us, do everything just to save a child. And this is something that we have to really think about, affordability. Because if you can do something to prevent deaths and prevent disabilities, the cost will follow. And the same with relevance of new vaccines. Why do we use a new vaccine? You have to study whether or not it is relevant to your country, because not all countries have the same epidemiological and distribution of diseases. Some countries have high measles, some countries have none, some countries have Lyme disease, some countries have other diseases that are not present in other countries. And that's why we have to see whether that vaccine is relevant in our setting. Now, let me just go back to adverse event, because adverse event, again, if we talk about safety, we always think that adverse events are what we are afraid of after a drug or after a vaccination. So it is any medical event that follows vaccination. We call it AEFI, adverse event following immunization. It may be a true consequence, or it may only be coincidental. And the thing to do is investigate and do whatever necessary in order to show whether it is a true adverse event or related to the vaccine, or it could just be coincidental. And there are procedures to do that. As far as adverse reaction, and they're not similar, they're not the same, adverse reactions are unintended effects caused by the vaccine. Usually, these are the local side effects or the systemic side effects. And what we call them is because they are already investigated. Going back to adverse events, we say before that it is not always true, and maybe this is really far from the truth, that everything that happens after a procedure was caused by that procedure. What we call temporal association does not necessarily prove causation. Just because one event follows another does not mean that that first caused the second. And we have to remember that definitely these are needing investigation. Again, adverse reactions are things that have already been shown by clinical trials, by post-marketing surveillance, which are already associated and related to the vaccine. Some of these are listed down here. You have BCG, reaction site, lymphadenitis, disseminated disease. You have whole cell pertussis vaccine, which can cause, one of the most severe is HHT. That's hyporesponsive, hypotensive episode, which can actually cause sometimes death, because if they aspirate during this time and the mother does not see it, it can actually cause choking and aspiration. So an HHE is sometimes very important to tell the mother to always look after their baby after the injection of whole cell pertussis. All right. Of course, there have been also episodes or events of encephalopathy and anaphylaxis from whole cell. That's the reason why many countries do not want to give whole cell. But whole cell pertussis is a very immunogenic vaccine compared to the what we call acellular pertussis, which does not cause this adverse reaction, but also are less immunogenic and can cause waning of immunity. So, OPV is something also that we have to look at because it can cause vaccine-associated paralytic polio because it's a live vaccine. And down the line, you have many things that can cause adverse reaction that are already in place and are already proven. Now, they can be very common, uncommon, or rare. We do not want very common occurrences, but we always look at the very rare to enable us to really use that vaccine. Now, just to let you know that if you do have an adverse event, the investigation, as I said earlier, can be used to prove that this vaccine did not cause the disease. And we have this formula that if you have been vaccinated, you compare the occurrence of the disease in a population who were vaccinated, compare that disease to those who were not vaccinated. This is the formula that we are using so that we can show that those in the vaccine group, if indeed there is a higher rate of that incident in the vaccine group versus those that are not vaccinated, then you can say, yes, the vaccine may be the cause. This is how the MMR spectrum disorder was proven not to be caused by vaccinating with MMR, because if you look at this, the risk in the vaccine group of ASD is in fact just the same, almost the same, 7.83 per 10,000 versus those with no vaccine, 7.96. So your MMR and autism does not hold water. Now, we also need to realize that vaccination must reach a threshold, what we call herd immunity, to produce herd immunity, so that even those who have not been vaccinated may not suffer from the disease. And for those with a high relative transmission rate, like measles, you need a higher coverage for the whole population to attain herd protection. As I said, herd protection is for those that have not been vaccinated but can benefit because you have a 90% coverage. And this is an ideal one, that you have a high coverage so that outbreaks will be prevented. Now, let me just, in the next session, come up with the issue on what happened to the Dengvaxia. It's a tale of vaccine safety miscommunication. And mind you, dengue is a disease that is so actually part of the top 10 global health issues in the world today. It is a fast emerging pandemic. It has increased in the last 50 years by 30-fold. It has an estimated 390 million dengue infection, with 294 million without any clinical signs when it attacked, asymptomatic. So you remember that. Not because you don't think it has, it's not there, it's not there. Because asymptomatic is almost 70 to 80% of cases. And that 70% of global dengue disease is in the Asia-Pacific region. Now, we know that in the Philippines, it ranks 8 in the leading cause of morbidity. And with more than 200,000 cases now occurring every year, that's a lot. And definitely it has increased. We have seen it increasing. The case fatality rate has remained at about 0.1 to 0.4%, which is in fact higher than that of our neighboring countries like Thailand. In fact, did you know that we are 10 times higher at risk of dying from dengue than our neighbor Thailand? They have a very good management of dengue. For some reason, our case fatality rate is higher by 10 times from that of Thailand. And thus, we need to, pick up our management for dengue. So, this is how it looks. We are increasing our dengue, and that is why we do need a dengue vaccine, because based on literature, based on observation, experiences, we do have insufficient prevention and control, lack of specific treatment, lack of prophylactic measures, the pressure to do more are needed for dengue vaccination. But what happened? The first promising vaccine to protect against dengue fever, which was a step forward in fighting the disease that afflicts millions, was actually started in the Philippines, also in Brazil, also in Singapore. But what happened in 2017, November, was Sanofi, the manufacturer of this vaccine, announced that based on the 6 years of clinical data, Dengvaxia provides persistent protective benefit against the dengue fever. But what was so overwhelmingly reacted to was that more cases of severe dengue could occur following vaccination upon a subsequent dengue infection. This actually, the effect was tremendous. The Philippines made headlines with public outrage and a suspension of the vaccine program, as well as threats to sue the manufacturer. The new recommendation is that until more conclusive results are made available, the vaccine should no longer be administered to people who have never had dengue before. And it has created panic and hysteria among vaccinees. Why people were saying that the parents were not informed of this Dengvaxia's adverse effects. And then suddenly, just created chaos. Looking back, what happened actually? As I said, the Philippines is the first in the world to launch a mass immunization. It was also started in Brazil. The vaccine is also approved in Mexico. And right now, in 2018, 20 countries has already approved that vaccine, the Dengvaxia. But because of that announcement by Sanofi, which from what I gathered, did not have any consultation with the Department of Health nor with any other local people there, they just made that announcement, not realizing what impact it would do. But if you realize what happened, 29 November, the announcement was made. November 30, Dr. Antonio Danz, a medical epidemiologist at the PGH, who had previously called for screening of dengue status before vaccination, posted that our heart bleeds for the over 600,000 children who received dengue vaccine without assessment of prior infection. This post spread like wildfire, contributing to the public panic and increasing the political interest in investigating the seemingly fast procurement of the vaccine and launch of the immunization campaign under the previous administration. This post was followed by a video that also went viral. Radio, TV, and social media all rallied around the news vilifying past officials. December 1, what happened? The Ministry of Health suspended the school-based dengue vaccination program. December 4, Sanofi updated and clarified the announcement, but it was too late. The Philippine FDA withdrew the approval of the vaccine. December 20, President Duterte, the current president, even announced in media that he would have done the same, realizing the dengue vaccine need, as what the Secretary of Health previously had done. But then, former President Aquino was called to the Senate inquiry and then started the whole communication mishap on Dengvaxia, because the Senate committee, the hearings, found probable cause against former President Aquino and former Health Secretary Guerin. What happened next? Well, we do know that during the interim, Sanofi returned the money to the government for the unused vaccine, the equivalent of about half of the total procurement. The Public Attorney's Office and supposed experts claim numerous deaths caused by Dengvaxia. And as you know, there has not been a proven single death caused by the Dengvaxia. When I say proven, this is evidence-based, but this has already now resulted in a significant reduction of the EPI vaccination. All the vaccines, even the warming, all public health programs started to deteriorate. People were all afraid. They distrust the government. They distrust vaccination. They distrusted everything that the government stands for. And that is when we now look at our measles outbreak. In the past several months, we have seen outbreaks right and left, Zamboanga, Davao. Most of this may have been because when they looked at the vaccine confidence in the Philippines, and this was published by the director of the vaccine confidence in the London School of Hygiene, we have a decrease of 93% vaccine confidence in 2015 to 32% vaccine confidence in 2018. And mind you, this is not just a publication. We in the community can feel it. We can feel the people in the barangays, in the community really fearing. Even you, maybe in the private sector, have been questioned by your patients on whether or not this vaccine is safe, whether they should continue with the vaccination, because chances are they will defer their vaccination until much more light, they say, has been given. So what went wrong? What or who is to blame? Are these the policymakers, the decision makers, the pharma companies, the experts, the media, the lawyers, the health workers, the politicians? Are there others? What went wrong in the dengue vaccination in the Philippines? You know, before introducing a new vaccine, especially dengue vaccine, there have been standard procedures where this followed, like the establishment of a good communication and advocacy plan. Were we able to identify all the partners and stakeholders? Did we conduct a research or a pilot project prior to the national or subnational introduction? Did we consider that vaccine is an investment in health and not as a political tool? These things are the standard WHO recommendations before new vaccines, especially dengue, is introduced in a body. And we have publications. We look at literature and see that maybe it's not also in the Philippines at all. There have been many instances where vaccine confidence in government in vaccine have failed because there are many issues to really address. And these are public concerns, not just about safety, but the policies, the recommendation, the vaccine cost. You know, we spent 3 billion on that vaccine. Was it, as I said, affordable? Was it relevant? Those are the things that you address before these things. You know, I'm not a public health person. I'm an infectious disease. But we study these things. And that's the reason why we look at all this before you introduce a new vaccine. The public decision-making is driven not by scientific evidence, but a mix of scientific, psychological, sociocultural, and political reasons. The internet and social media have emerged as a rapid and powerful sources for information, just like what we saw. The examples on Dengvaxia really show that the social media is the most powerful tool, especially when it is in the negative. Positive communication on vaccine safety and risk-benefit alone cannot stop public distrust and dissent against vaccination. The levels of public trust on vaccines are very variable, and it needs the understanding, the public concerns, experiences, religious, political affiliation, socioeconomic status. The core principles to be followed definitely, and this is very important, is to listen to one another. There's no one man who can do that. You have to be transparent in decision making. You have to be honest and open about uncertainty and risks. And definitely, what do we do next when these are not being settled, even if you address it? And these are some of those things that you can do. Strategies. What is the way forward? Who needs to do what? And we are now in the midst of this crisis. We need to build up public trust, and this should be locally tailored. We need to have a risk communication that is evidence-based, with transparency and honesty exhibited in decision-making. We need a systematic approach in listening to public concerns, with accompanying surveillance, monitoring, and prompt response to public confidence, building public confidence. We need research for decision and policy makers to understand what the public wants, especially in introducing new vaccines. And there should be models in multidisciplinary research for vaccine introduction, technical, operational assessment, social and political factors included in monitoring. Ladies and gentlemen of the webinar, UP webinar, Thank you for listening. Now, I'd like to challenge you. This is a call to action. The time is now. Our country is in a health crisis. I was just talking to some of our public health officials. The country is bleeding. The country could be or soon be called the sick country of Asia. Why? Because our country is exporting missiles all throughout the world. We have 10 million overseas Filipinos. They're exporting our missiles. Pertussis, diphtheria, they are waning in immunity. And there might come a time when even our balikbayans might not come to our country if we have all these outbreaks, if we have all these diseases coming in and out. Worse is, we may not even be accepted to their country if we go traveling, because they might think, just like what happened to that Filipino or Australian who went to Australia. He was quarantined because he showed signs of measles on the plane. He was quarantined, risked to a hospital right away upon his deplaning. And we don't want that. It's so embarrassing. And not just embarrassing, it's really pitiful for our country. The health professionals should serve as the credible voices for the value of vaccines and recruit the other advocacy voices. Ladies and gentlemen, whether you do videos, whether you do dengue activities, white papers, writing, publications, whether you do fun run around the city to sort of raise awareness on the value of vaccines, whether you do a dengue dance like Eric Tayag here, who did a dengue dance way back in 2013 to raise awareness to prevent the high incidence of dengue, whether you do vaccine missions, such as, raising again people's awareness to give vaccines to protect our children, to save them from disabilities and deaths. Whether you do press cons, media, radio interviews, whether you do slogan making contests, just like what we did. See, even students are now very critical in doing their slogan. This was our first place winner. Sakit ay agapan, bakuna ang panlaban. You can even do songwriting. You can do even poster making. Various places we have gone through, they are very much keen on doing something to raise awareness on the value of vaccine. They even have cake layering, a covenant. For every covenant, a layered cake. To say that everyone needs to do something. But whatever it is, we need solutions that are innovative, creative, and fresh. Because, ladies and gentlemen, you are much needed. Remember that inequality is always a tragedy. Justice in healthcare is the most inhumane, according to a dreamer, Martin Luther King. So please never be idle, but be reading, writing, listening, meditating, or endeavoring something for the public good. Thank you very much.
Thank you very much, Dr. Bravo, for that very excellent and very enlightening and insightful lecture. So, first, before we do the questions, I would like to thank today's sponsor, Merck Sharp and Dome MSD. My first question is on the expanded pediatric immunization program of our country. Who really decides what kind of vaccine should we incorporate in the program?
Well, the ultimate one is the Department of Health Secretary. Okay? He has the final say on what vaccines need to be done. But he does not make it alone. The decision is always through a committee, a group. Standard procedure is there is an immunization committee that has the expertise to look at all the essentials to introduce vaccines into the country, like the burden of the disease, that is supposed to be the infectious disease people, the epidemiologists to look at the burden and the distribution of the disease. You have the public health to see the health system structures. You have the public health and the infectious, the pediatrician to look at the country's children, how they react to this, what possible adverse events. And of course, you have the health economist, which compute the cost effectiveness of the vaccine. They're all to be included in a committee, so-called the National Immunization Technical Advisory Committee, that makes those decisions. You know, it cannot be just one person alone.
Thank you. You know, as an oncologist, I see how varicella infection can delay chemotherapy and has a high fatality rate for children with cancer. I was wondering, it is not included in the API. Do you think it should be included, and what other vaccines should be included in our program?
Right. You know, the PIDSP, the Pediatric Infectious Disease Society of the Philippines, together with the Philippine Foundation for Vaccination and the PPS, have come up with a schedule of immunization that includes varicella as one of the recommended vaccination. And even in other countries like the US, it's already placed as an EPI. Mm-hmm. However, in the Philippines, because previously it did not have so much mortality, it did not have so much deaths, and as you say, only in those with cancers, you know, they did not put it there because of the cost. Because initially, varicella is very expensive, or was very expensive before. Now it has diminished in price because the greater the volume always dictates the price. The bigger the volume that you use, the lower the price of the vaccine. And through the years, because of the increasing volume of the usage, then the price decreased. And that's always the history of vaccination. Mm-hmm. It always is most expensive during the first years of its use, and then it's Now, definitely, we want varicella to be there because right now we are also seeing that varicella, even for non-cancerous, non-immunocompromised patients, can also cause a severe disability, even encephalitis, even pneumonia. It can cause, especially if you are an adult. Many or beyond 7 years old, it's in fact less severe in the younger people. And the reason is because they still have some antibodies that they got from the mother.
Okay.
But if they do not have any more maternal antibodies because of waning immunity, then it's possible they can also have a very severe disease. So let's put it there. The only problem is the cost always. As I said, before you introduce a new vaccine, you have to deliver the cost effectiveness. And let's say if the Department of Health economists say that, you know, the vaccine is so much more costly compared to the number of deaths that we can prevent, you know, that's when they will say, okay, let's go for another priority vaccine. Because they will look for a vaccine that has higher mortality rates than varicella. Anyway, varicella, you know, you can always be popular with varicella in ladies who do not want to have scars in their faces.
Yes. So I've heard from the news, right, that it's not just here in the Philippines that the measles outbreak is happening, it's also worldwide. But I was wondering if you can discuss a little bit more, how do we compare with the rest of the world in terms of measles and other preventable infections through vaccinations?
You know, Tricia, in 2005, measles was almost gone. We had 0 incidents of measles. We had no deaths from measles. 2005, after the government came up with a massive measles immunization in 2003, 2004. 0. Can you imagine when before we had something like 1,000 deaths from measles every year? Prior to that, late 90s, we had 1,000 to 2,000 deaths of measles every year. Sometimes during epidemics, it could even increase to 5,000 because the case fatality for measles, mind you, in those hospitalized is almost 8 to 10% of hospitalized measles cases. That's a high fatality rate. But then we started to be complacent. From 2005 to 2010, there was no disease so much. Nobody thought that it is an important disease anymore. And that's when we started losing out on measles coverage. And from a high of 90-95% coverage of measles, we started to go down. And in areas, especially in the South, Mindanao, where vaccination is not very much kind of talked about or valued, then that's where most of these outbreaks now will come. Because there was a time in 2010 when the Department of Health said that any one case of measles is already an epidemic, an outbreak because they did not want the epidemic. Now, in the Philippines and in other countries, this is what's happening. In most parts of the world, it's eliminated. In our neighbors, among our neighbors, Thailand, Malaysia, you don't hear measles as much as we have now. In fact, I will tell you, in the latest WHO WIPRO announcement, the Philippines is now compared to Papua New Guinea in terms of the measles. And it is so embarrassing to know that we are also exporting measles all around the world. Diba? In Disneyland, in Europe, 10 million people are going around the world, and they are bringing with them many of these diseases that could have been gone a long time ago. So maybe think about that. We have to challenge every health professional, medical practitioners, to really talk to their patients about covering measles, pertussis, diphtheria. You know what's worse? We have eradicated polio already, right? Since 2000 in the Philippines. There are only 2 countries now that has polio, and that is Afghanistan and Pakistan. And we are really looking at, sooner or later, by 2030, polio is eradicated from the world, just like smallpox. But there's still 2 countries. Now, if the Philippines, because our coverage for EPI is down to 30 to 50%, and we get polio, God forbid, nobody will really come to the Philippines. It's such an issue that will redound through almost all corners of the world, that the Philippines is now a country called, not the IPAP, not the vaccine-associated one, because that's the reason why we are now removing the oral polio, because we don't want the IPAP. Just 1 out of every 1 million doses you can get the vaccine-associated polio. But the wild polio that is now eradicated, if it comes back to the Philippines, it's gonna be such a disaster.
Dr. Brown. So, thank you. I'm sorry for my cough. I did not get the flu shot this year.